His name was Gerald, 71 years old, retired engineer, sharp as anyone you'd meet, crossword puzzles in pen, remembered every birthday in the family without a reminder. He had a hip replacement, routine procedure. The surgical team called it a success. 3 days later, his daughter picked him up from a hospital. She told me, and I want you to hear exactly how she said it. She said he came home, but he wasn't all the way there. He forgot where the bathroom was. He called her by her mother's name. He couldn't finish sentences he'd started. His daughter thought he was just tired from the surgery. The nurses said it was the pain medication. His surgeon said it was normal. Nobody used the word. Nobody told her there was a word. Write this down. Post-Operative Cognitive Dysfunction. POCD. It affects up to 40% of adults over 60 in the first week after major surgery involving general anesthesia. 17% are still experiencing measurable cognitive changes at the 3-month mark. That is not a footnote. That is not a rare complication. That is a condition that may affect nearly half of older adults going into surgery, and the vast majority of families have never heard of it before it happens to them. This video is education, not medical advice. I am not a physician. What I am is someone who reads the research, and today I'm going to walk you through what the evidence actually shows about what anesthesia can do to the aging brain, why it happens, how long it can last, and, most importantly, what questions you or someone you love should ask before signing any consent form. Because never signing a consent form after 60 without asking these questions, that's not fear, that's preparation. Before I go further, drop a comment right now with just your age, nothing else. I want to see who's watching this. Here is what the system assumed for decades, that cognitive changes after surgery were caused by the stress of the procedure itself, pain, sleep disruption, being in an unfamiliar environment. The anesthesia, they said, cleared your system within hours. Once it was gone, it was gone. The research now tells a different story, and that gap between what the science has found in the last 10 years and what is still being communicated to families before surgery is costing people something they can't get back. Gerald's daughter signed the consent form. She initialed every page. She was told about infection risk, about blood clots, about the small chance of surgical complications. She was never told that her father's brain, specifically because it was 71 years old, would respond to general anesthesia differently than a younger brain does. Nobody told her that. She was prepared for a hip to heal. She was not prepared for the man who came home. In this video, I'm going to cover 4 things the evidence now shows, and one of them is going to change the conversation you have with any anesthesiologist before any procedure for the rest of your life. Has someone you love ever come back from surgery and seemed different? Not just tired, but different? Drop it in the comments. You are not alone in this. In January 2024, Frontiers in Behavioral Neuroscience published a comprehensive review of the current research on post-operative cognitive dysfunction. What researchers found was not reassuring. The aging brain, and this becomes increasingly true after 60, does not process general anesthesia the same way a younger brain does. The mechanisms are multiple, and I want to walk you through them clearly, because understanding why this happens is the first step to knowing what to ask. Mechanism 1. Neuroinflammation. General anesthesia triggers an inflammatory response in the brain. In younger patients, that response is typically short-lived. In older patients, the inflammatory cascade can persist, and neuroinflammation, sustained over days or weeks, disrupts the way neurons communicate with each other. Think of it like static on a phone line that won't clear. The connection is still there, but the signal keeps getting interrupted. Not in everyone, but in a meaningful percentage of patients over 60, that static doesn't clear as quickly as it should. Mechanism 2. Intraoperative hypotension. During surgery, blood pressure drops. That is expected and managed. But in older patients, even brief episodes of low blood pressure, what researchers call intraoperative hypotension, can reduce blood flow to the brain at exactly the moment when the brain is already under pharmacological stress. For a younger brain, that window is narrow and recoverable. For a brain at 68 or 74, the margin is tighter. A 2023 systematic review published in Neurology, impact factor 9.91.
19 studies covering thousands of patients found a 94% positive correlation between anesthesia exposure and measurable cognitive changes in older adults. Write this down. 94% positive correlation. 19 studies. This is not fringe research. This is published in one of the most rigorous neurology journals in the world. Now, before anyone stops reading, I want to be precise about what that means and what it does not mean. A correlation in this context means that in study after study, researchers observed measurable cognitive changes following anesthesia in older adults. It does not mean that every person over 60 who goes under general anesthesia will develop permanent cognitive decline. What it means is that the risk is real, it is consistent across the literature, and it is not being communicated to patients the way the evidence warrants. Let me tell you about Margaret. Margaret is 67. She had elective abdominal surgery, not an emergency, not cancer, a quality-of-life procedure her surgeon had been recommending for 2 years. She went in organized, independent, managing her own finances and her own calendar. After surgery, for 6 weeks, she couldn't hold a grocery list in her head long enough to get through the store. She lost track of conversations mid-sentence. She told her daughter she felt like she was thinking through cotton. At her 6-week follow-up, she told her surgeon. He told her it was likely post-operative fatigue and that it would resolve. It did resolve. By month 3, she was largely back to herself. But those 6 weeks were frightening for her family. Nobody had given her a name for what was happening. Nobody had told her it might happen. Nobody had told her it was likely to resolve, which meant she spent 6 weeks not knowing if it would. That is the gap. Not that POCD happens. The gap is that families walk into surgery without knowing it can. There is also a distinction I need to make because these two conditions get confused and the difference matters. Post-operative cognitive dysfunction is what we've been discussing, a pattern of measurable cognitive changes that develop after surgery and can persist for weeks to months. It is subtle. The person is functional but slower, struggling to find words, losing the thread of a conversation. It can be invisible to a medical team that isn't looking for it. Post-operative delirium is different. Delirium is an acute state of confusion that typically develops within the first 24 to 72 hours after surgery. It involves disorientation, agitation, sometimes hallucinations. It is more dramatic and more immediately visible, and it is also more common than most families expect. Up to 50% of older surgical patients experience some degree of post-operative delirium. I want to tell you about one more person. His name was Robert, 66 years old, cardiac surgery, a bypass procedure his cardiologist had been recommending for 18 months. His wife drove him to the hospital at 5 in the morning. She kissed him before they took him through the doors. He squeezed her hand and said, "I'll see you on the other side." The surgery went well, technically, but on the second night in the ICU, Robert started talking to people who weren't there. He pulled out his IV line. He told the nurses his wife was trying to poison him. He didn't recognize his son when he came to visit. His family was terrified. They thought he had had a stroke. They thought they were losing him permanently. What Robert experienced was post-operative delirium, acute, frightening, and in his case, fully resolved within 4 days. His family had never heard the word delirium used in a post-surgical context. They had no framework for what they were watching. They spent 4 days in a kind of grief that didn't need to happen, not because the delirium itself could have been prevented, but because nobody had told them it was possible. The two conditions, delirium and POCD, can overlap. A patient who experiences delirium is at a higher risk of developing POCD in the weeks that follow, but they are not the same, and the window for observing each is different. Delirium, the first 72 hours, POCD, the weeks and months after discharge. Before I get to the third finding, the one that changes the conversation you have with your doctor permanently, have you or someone you love been told about POCD before a surgery? Drop yes or no in the comments. I want to know what's actually happening in these pre-surgical conversations. If you had known this information before a family member's surgery, what would you have done differently? Here is the finding that most families never hear, and I want you to hear it clearly, not.
Research published in Aging Clinical and Experimental Research in 2024 found that the prevalence of POCD was 36.6% in younger adults and 42.4% in adults over 65. That gap, 6 percentage points between younger and older surgical patients, reflects something that researchers have been studying for years. The aging brain is not simply a slower version of a younger brain. It has a different baseline of neuroinflammation. It has less cognitive reserve to absorb insults. It has a narrower margin between function and dysfunction. But here is the part most people skip over when they read these numbers. POCD, in the majority of cases, resolves. The trajectory for most patients is measurable decline in the first weeks, followed by gradual return to baseline over the following months. Permanent cognitive impairment attributed purely to a single anesthetic exposure is not the typical outcome. The concern, the legitimate evidence-based concern, is for a specific subset of patients, those who already have subclinical cognitive vulnerability before surgery, those who may have early-stage neurodegeneration that has not yet surfaced. For those patients, the inflammatory insult of general anesthesia may accelerate a process that was already underway. And that connection between POCD and the longer-term trajectory toward Alzheimer's disease and other dementias is an active area of research. The data does not support saying that anesthesia causes Alzheimer's. What the data does support is that older patients with existing vulnerabilities may experience an acceleration of cognitive decline following major surgery. This is why the pre-surgical conversation matters, not to avoid necessary surgery, to walk in with eyes open. Now, and this is where I want to shift because the evidence also identifies modifiable risk factors, things that can be addressed before the procedure, during the procedure, and in the 72 hours after. Before surgery. The evidence supports what researchers call prehabilitation, not rehabilitation, prehabilitation, optimizing the patient's physical and cognitive baseline before elective surgery. This includes aerobic conditioning in the weeks before the procedure, sleep quality, nutritional status, and, critically, a full medication review. Certain medications, extremely common in adults over 60, interact with anesthetic agents in ways that increase cognitive risk. This is a conversation to have explicitly with the anesthesiologist, not assumed to be covered in the standard pre-op appointment, because in most cases, it isn't. During surgery, intraoperative hypotension is a modifiable risk factor. Anesthesiologists who are explicitly aware of a patient's cognitive risk profile can manage blood pressure targets more conservatively. This is not automatic. This is not standard protocol everywhere. It becomes part of the plan when the patient or the family asks for it by name. There is also an emerging body of evidence on regional anesthesia versus general anesthesia for certain procedures. For some surgeries, regional anesthesia, which does not cross the blood-brain barrier in the same way, may carry a lower cognitive risk profile for older patients. The evidence here is not definitive enough to make a universal recommendation. Individual anatomy, surgical complexity, and clinical judgment all factor in. What the evidence is strong enough to support is a direct, specific question asked before the consent form is signed. After surgery. The 72-hour window after major surgery is the highest risk period for both delirium and the onset of POCD symptoms. Families who know what to watch for are not helpless. They are the most important observers in the room. Watch for new confusion not explained by pain medication, difficulty recognizing familiar people or places, inability to follow a simple conversation, significant personality changes, irritability, withdrawal, agitation that feels out of character, sleep disruption beyond what the hospital environment alone would cause. When you see these things, document them. Write down what you observed and when. Bring those notes to the medical team, not as accusation, as data. These are not signs that something went permanently wrong. In most cases, they are signs that the brain is under acute stress and that the family is the first line of observation. A recommendation is not a verdict, and a family that knows what to watch for is not a frightened family. It is an informed one. What would you add to a pre-surgical checklist for anyone over 60? Drop it in the comments. Some of the best insights in this community come from people who've been through it. I want to be clear about something before I give you the practical part of this video. Nothing I've told you today is an argument against surgery.
If your surgeon recommends a procedure, if the clinical evidence supports it, if the quality of life benefit is real, and the risk of not operating outweighs the risk of operating, then the answer may well be to have the surgery. What I am arguing is that you are not a passive recipient of medical decisions. You are an informed participant in your own health and in the health of the people you love. And being informed in this case means walking into the pre-surgical consultation with 3 specific questions that the evidence supports asking. Write them down before the appointment. Bring them on paper. Ask them out loud. The anesthesiologist is the right person to receive them, not the surgeon, not the nurse at the front desk. The anesthesiologist. Question 1. What is my specific risk profile for post-operative cognitive dysfunction, given my age, my current medications, and my cognitive baseline? This question does 3 things. It tells the anesthesiologist that you know what POCD is. It opens a conversation about your individual risk factors, and it signals that you expect this to be part of the pre-surgical assessment, not an afterthought addressed after you're already in a gown. Most anesthesiologists, when asked directly, will engage seriously with this question. The research supports the concern. The conversation just rarely gets initiated by the patient because patients don't know to initiate it. Now you do. Question 2. Is intraoperative hypotension management something we can discuss given my age? Are there blood pressure targets during the procedure that would be appropriate for my cognitive risk profile? This is a more technical question, and it is designed to be. A family member can ask it on behalf of the patient. Writing it down beforehand is not just permitted, it is encouraged. The anesthesiologist cannot promise a specific outcome, but they can acknowledge the concern, factor it into their monitoring targets, and make it part of the documented plan. Question 3. Given my procedure and my age, is regional anesthesia an option we should evaluate? And if not, what is the clinical reasoning? You are not demanding regional anesthesia. You are not second-guessing the surgical plan. You are asking whether a conversation is warranted. The answer may be no, and the no may be entirely appropriate for your specific procedure and anatomy. But asking the question puts POCD on the table before the consent form is signed, not after the patient comes home changed. Write these 3 questions down right now, not for yourself, for whoever in your life might be heading into surgery, a parent, a spouse, a sibling, a friend who trusts you to help them navigate the system. Because here is what nobody told Gerald's daughter, and what nobody told Margaret, and what nobody told Robert's wife in that ICU waiting room. The complication is known. The risk factors are known. The window for intervention is before the procedure, not after. And knowing the name for what happened does not undo the shock of watching someone you love come home changed, but it changes everything about what the family does next. Let me leave you with a 30-second recap. 1. Post-operative cognitive dysfunction is real, documented, and affects up to 40% of adults over 60 in the first week after major surgery. Most cases resolve, but the trajectory varies, and the risk is higher in patients with existing cognitive vulnerability. 2. The aging brain responds to general anesthesia differently. Neuroinflammation, intraoperative hypotension, and pre-existing subclinical decline are all factors the evidence identifies as modifiable or observable. 3. There are 3 questions you can ask before any surgery. Write them down. Ask them of the anesthesiologist, by name, before the consent form. The conversation belongs in the pre-surgical appointment, not in the follow-up visit 3 months later. If this video gave you something you didn't have before, drop "informed" in the comments. That word tells me you walked away with something you can use. And if someone you love is heading into surgery, share this video with them. Not to frighten them, to prepare them. Coming up next, we look at the medications most commonly prescribed to adults over 60 that interact with anesthetic agents, and what your pharmacist may not have flagged before you walked into the OR. Which of the 3 questions would you have wanted someone to ask on your behalf, or on behalf of someone you love? Tell me in the comments. This video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare provider before making any decisions about surgery, anesthesia, or any aspect of your care. The research cited here is real. The application to your specific situation requires a conversation with your medical team.